Natasha Pillay Smiley. I have the privilege of being one of 4 pediatric neuro-oncologists downtown Chicago. We have a wonderful, amazing team, and when I came on as an attending last year, I established a brain tumor survivorship clinic along with Katie Valentino. And also in our panel is Dr. Stephanie Powell, who's one of our pediatric neuropsychologists that you guys who are here with us met this morning. The main focus of what I'm trying to discuss today is that you need to take ownership of your own medical care. And the one thing that drives our clinic is that there is nothing medically that is beyond your grasp, either as a child, a young adult, a parent of any age. If you have the right guidance from your medical team, there's nothing within your grasp to understand about your tumor, about the late effects, or anything like that. So there's some, this is medical heavy, but I think it's important to go over specifically the challenges that our survivorship population faces. We'll also talk about the multidisciplinary approach necessary to provide care for our survivors and what can survivors and their families do to remain actively a part of their care. So the facts we want to talk about: cancer is terrible, having a brain tumor is terrible, and over the last several decades we've been so focused on curing that cancer that it's been, we wouldn't take any prisoners, meaning that any late effects would be a positive thing because you would be surviving long enough to have a late effect. And so that is the mode of operation that we've all been in as a community, and that has its positives and negatives. I have the privilege of being mentored by Dr. Stu Goldman. I see one of our kids in the audience that knows Stu very well, and he's been instrumental in the neuro-oncology field. And one of the things he also has isms. He has Stu-isms, and one thing he's taught me is the cost of a cure is paid over a lifetime, meaning after your tumor is cured, you have these things that you deal with, and it doesn't end when you stop seeing us in clinic. It continues through your day-to-day life, either in big ways or small ways. And that's just a reality of what you guys are facing. It takes work and a multidisciplinary approach to have our patients live active, healthy, and fulfilling lives after surviving cancer. Work and multidisciplinary are the 2 words that are important here because it's not easy. So you need to be in a place, just like you guys are in here, where you have champions for your cause. You have people who understand what you went through and can help you figure out what exactly you have to face in the years to come so that you can live good, happy, fulfilling lives. And so recently, I'd say probably in the last year or 2, we've been focusing on our survivors. And when I say we, I'm talking about families, patients, and also from a medical perspective, we're now looking at ways that we can reduce therapy and have the same outcomes, meaning having people survive just as well, but maybe try and trim down some of the late effects from it. So who are the survivors? So there's no national definition of what survivorship means. For most people and for us in our team, we defined it as you become a survivor when you have completed 3 years from the very end of treatment. Not from the beginning of treatment, but from the last chemotherapy dose. That includes 220,000 people in the US, and 1 in 2,000 adults used to have childhood cancer, and that last statistic is nationally from 2000. And that means 1 in 450 adolescents. Now, this is not brain tumors alone. This is including all pediatric oncology. As you guys know, one of the most common cancers to affect our children are leukemia, and the second one are CNS tumors. Unfortunately, mortality from CNS tumors is almost 3 times as high as that in patients with ALL. I'm going to show you a couple graphs, and I didn't put it up here to go through them in detail, but I'm going to guide you through them just so that you can kind of get a gist of where we've been and where we're going. So the yellow line here are the deaths that were averted, and so as mortality is going down, deaths averted are going up, meaning more kids are surviving over the period of time. So this is 1975 to 2005, so that's a very positive thing. If you look specifically at children with brain and spine tumors, this is categorized according to age. So the blue is infants, so 0 to 4. Middle-aged children are in yellow, 5 to 14, and gray is 15 to 19. Overall, the bars are going up, which means more kids are surviving. But if you look at the nitty-gritty, you can see that we still have a long ways to go as far as actually curing our children. If you look at the infant subsection from 1975 to 78, 51.6% of children survived compared to 71% around 2000. We see that as a remarkable thing, but that also means that we have a long ways to go as far as cure is concerned as well. I wanted to show you this too because a lot of you in the room probably have a tumor called a low-grade glioma. For years, we knew that children with low-grade gliomas would grow up to become adults and they would be affected by the tumor and the chemotherapy and things like that, but we don't expect those children to necessarily pass away from those tumors because they're slow growing. We never had evidence of that until last year, where we were able to compile data nationally, and we were able to see that these children with low-grade gliomas grow up to become adults, and they become adult survivors into their 70s and 80s. And yes, they have a lot of late effects, but they live long lives. That doesn't mean they're not affected by their tumor or what's going on, but that's new data that was presented last year. And the two bars, the one in the top one in black shows that those children that received no radiation, at the ones at the bottom are the kids that received radiation. So our big push over the years is because low-grade gliomas are slow growing, we wanted to save you from the effects of radiation. So you would not have to deal with that overall, and this just verified that that was the right approach. Because as you can see, if you did not receive radiation for your tumor, you tended to live longer than if you did. Our guess, even though that our educated guess, even though if we don't have that data specifically, is that the children that received radiation at a very young age and had a secondary malignancy when they got older. So what's the cost of a cure? I'm not going to go into these tumors in detail, but these words are probably familiar to all of you. There's a very aggressive tumor that was universally fatal about 15 to 20 years ago called an atypical teratoid rhabdoid tumors, an ATRT. And now we have survivors. We never had that before. But at what cost do we have survivors? We've had to treat our infants with radiation to the brain and spine. We've had to give those same infants very high-dose chemotherapy that caused effects to their hearts, and we had to give chemotherapy into their spinal canal to help clear those tumor cells as well. For germ cell tumors, again, we've done radiation to the brain and spine, and we've almost doubled the success rates. Now it's very uncommon for children with germ cell tumors to not survive, but we've had to give radiation and we've had to give chemotherapy, a few cycles of it, before we even radiate them. Medulloblastoma has been a huge success story as well for us, but again, it's giving craniospinal radiation to very young children and giving very intensive chemo. So one question I'm always asked is, why should you be a part of a brain tumor-directed survivorship clinic or survivorship team instead of just a general oncology survivorship team? And the answer is our children are affected by their tumors and what we use to treat them in very different ways than children would, say, leukemia or Wilms tumor or anything like that. So you need to be in a place where someone understands the effects that happen in brain tumor patients specifically. And so I'm just going to go over what those unique late and long-term effects are. So what's a late effect? It's any physiological or psychological problem arising after a cancer treatment is completed. It also includes potential problems, so things that are not happening to you now, but things that we have to, as a medical team, need to make sure never happen to you. And we can go over those as well. And how do we know what those are? The Children's Oncology Group standardized what our screening and treatment practices are. So all survivorship clinics will use a a screening and treatment protocol based on how much radiation and how much chemotherapy you got. So really, no matter where you live in the US, at least you have that. There should be a standard of care, which there often is not in oncology, but there is for survivorship. So at the very base, there are specific things we know we have to look for, and if we look for those things, we can treat you for them as they crop up. So what caused these late effects? Location of the tumor, surgical resection, radiation, and chemotherapy. The brain is high-priced real estate, right? We can't do anything without it. If something happens to a kidney or an arm or a leg, we can maybe do without those things and move on. But when you do things to your brain, there are repercussions that you have to be aware of. And so that's why our late effects are unique in our population. Our brain tumor survivors themselves report that they have trouble with cognitive and physical effects, more so than children who have had leukemia or lymphoma or any other solid tumors. Physical functioning, specifically balance and running speed and agility, is affected, but these studies are done from questionnaires from survivors themselves of pediatric brain tumors, and those are things that they've had trouble with. Strength has not been an issue, and balance and coordination has been the same. And another thing that is often neglected to look at when we talk about what causes these late effects is many of our children have hydrocephalus, and what is that? We have large tumors that are blocking the flow of CSF or spinal fluid that are going around. And so if left untreated, that itself, not just the tumor, can cause late effects. So there's been studies that show that children, for example, with medulloblastoma have issues with verbal and nonverbal intelligence, the ability to use oral language, academic achievement, looking at visual motor integration and memory. And I know these are all things that Dr. Powell and her team have discussed with our survivors. Our children with posterior fossa syndrome is also something that we look at in our clinic. So those are children who have had tumors in the back of the brain, specifically medulloblastoma, and after it's taken out, you end up with something called posterior fossa syndrome about 30% of the time. So what happens is that those children need rehab in the acute period, but a lot of times when you're 5 and 10 years out, you might still have issues with a little bit of balance, a little bit of being able to say what you mean, or to fully process things, and all of those things are because the tumor was taken out of that area. So posterior fossa syndrome is an entity we've known about for a long time, but we've never focused on what does that mean for children who are 5 to 10 years out moving forward. We know that, again, with posterior fossa syndrome, when we looked at about 30 kids with medulloblastoma over a period of time, they struggled with their IQ being a little bit lower than those who did not have posterior fossa syndrome and also had medulloblastoma. So this compares patients with the same tumor. One was diagnosed with posterior fossa syndrome, one was not, and so we know that that has a huge disadvantage educationally and something we need to look at. Endocrinopathies, because of the radiation and the location of the tumor, a lot of our children have hypothyroidism. So what's important to note in brain tumor patients is a lot of times it's not, I'm cold, I'm constipated, all the things that we know to look for normally. A lot of times it's, I'm a little bit tired, my skin's a little dry, there's something not quite right, that I'm not functioning where I need to be. So what's important to note that unless you do the screening labs, you would never find this hypothyroidism in this particular group of patients. So you can have these survivors who are not operating at their full capacity, and it's something fixable. You can have a thyroid replacement drug, and you know, a lot of our children are on it and feel so much better afterwards. So this has been a huge win for us in the clinic, because this is something that's fixable, and we can make our kids feel a lot better pretty immediately. I'm sorry, this slide is a little blurry, but if you look at brain tumor patients compared again to other types of pediatric cancers, There's other things that we know to look for in these clinics as well, specifically reduced spinal growth, different types of endocrine issues where you're missing other hormones that are replaceable and fixable. And those are the hormones we're looking at: growth hormone, gonadotropic hormone, ACTH, and things like that. Osteopenia and osteoporosis is something that's often overlooked in our survivors as well. We know if you're male, if you happen to get growth hormone later on instead of more immediately, and if you have a lean body mass, all of those things are risk factors for having osteoporosis, and calcium supplementation is very important for these patients. And again, when you think of osteopenia and osteoporosis, you think about older women. And this is not the population that's at risk. More specifically, it's our other group. A lot of our kids have issues with growth, and it's not just from an endocrine issue. When you do radiation to the spine, you're actually reducing the potential of your spinal column to grow and expand. And so if you were radiated at a year of age, over a lifetime, you lose 9 centimeters. If you wait longer, so if you got radiation at 5 years or 10 years, your lost height is less, if I'm explaining that okay. Meaning the longer you're able to wait, the less height you're able to lose. And that's because your bones actually fuse sooner when you get radiation, and so your height potential is reduced. I bring this up because this is, height is an important thing to our survivors when it comes to how their physical outlook and their own self-esteem. It comes up in our clinic a lot. And so those are, besides growth hormone replacement and working with our endocrinologists, this is something that we discuss a lot in our clinics. Fertility is something that has been a huge push in the rest of oncology, but not so much in the brain tumor world until recently. We know that if you give radiation to the part of the brain that controls your hormones, you are more likely to have issues with your menstrual cycle, and you will need help in order to have a family. It doesn't mean you can't have a family, and so, but you just need guidance as you get older into how to make that happen. The reason that fertility has not been a big push, again, is because brain tumors are often not survivable, or if you don't act quickly, there's a chance that our children might not survive. So often we don't take the time to discuss the fertility effects of chemotherapy or what surgical interventions or anything like that can take place before the child receives any treatment in order to preserve that fertility. And this is something that we are now pushing in our clinic, and we think it's very important. And a lot of parents and both boys and girls, teenagers, are asking us directly about that. And so we're, as medical providers, trying to answer those questions and provide that need for them. So the way we explain what late effects are generally is that everything you worry about when you're starting to be in your 50s and 60s, diabetes, high cholesterol, strokes, all those things, we worry about our survivors when they're younger. It's not that those things are going to happen to them. It's that we need to make sure they're living good, healthy lifestyles, and there are things that we can modify so those things never happen to them. So things are just kind of accelerated. We always say you have to have a heart-healthy diet and exercise properly in order not to have those adult onset things. But especially true in our survivors. We harp on that from a very early age in order to prevent things like stroke and diabetes and heart disease happening. And it's something we push really hard, in even our youngest survivors, because we have evidence that, for example, our kids are at 100-fold increased risk than the general population of having a stroke. And that risk is increased if you've had radiation to the brain. But even if you haven't, just having a brain tumor by itself is a risk factor. So that's important for us to know that we can't change the past, but what we can change is what's your cholesterol, how are you eating, are you exercising, and those things are vital to pushing in this group. This is a graph that I've often reproduced for patients and their families in the survivorship realm, but also I also treat newly diagnosed patients. This is a a model, a computer model done at St. Jude. And it's a very good description of an explanation of the relationship between radiation and your ability to think and process things, or your cognition. So what it's showing is that if you, so the top line, the blue, is 12 years of age. The yellow is 11, and as you go down, it's younger in age. So the younger you are when you receive radiation, the more IQ loss you will have over time. It's not static, it continues. So if you were 12 or 11 when you were radiated, your IQ might stay at 100, or it might come down a little bit. If you were 5, even 5 years after treatment, that ability to gain information is not as high as it would be without radiation. And then there's the risk of secondary malignancy that we screen for in our clinic. One thing we have realized as practitioners is that the more we delve into family history, the more we're picking up to see if there's any familial predisposition to cancer happening in the family. The purpose of knowing that is that we can screen other people in the family, and we can do more adequate screening for our own patients as they get older. Radiation down the line can rarely cause meningiomas or a more aggressive tumor called a GBM. And then if you received chemotherapy, it increased risk of leukemia and myelodysplasia. So all of that sounds like extremely bad news, but I think it's important to know what you're facing, because from a medical standpoint, that's what we look for, but it's also important from a survivor standpoint and from a parent standpoint to know why we do the things that we're doing and to be an active participant in your healthcare, because then you guys know what to look for at home. These are not meant to scare you or to say that you shouldn't, you should be frightened by all these things because they're going to happen. It's rare that they're going to happen, but they may. And so it should empower you to be able to live a good, healthy life and do all the screening that we need to do, and help us figure out what additional things we need to do from a research standpoint to make sure those things don't happen. So again, survivorship programs are separate from the on-therapy clinic. So that's the one thing we did last year, is we took our kids out of, we have Wednesday afternoon clinics, so for our kids who are off therapy, we've removed those kids from that environment and put them in a separate clinic. We are focused on well-rounded care for the survivor, and that includes disease surveillance. One of the hugest psychological changes that needs to happen when you become a survivor is that we're now focused on not only looking to make sure the tumor doesn't come back, now we have to make sure that you're healthy healthy and happy in every other respect of life. That's a very hard transition to make as a parent and as a child. But it's important to be in an environment when you know we're still going to be getting MRIs. We're still making sure that your tumor looks exactly like it did every other time that we checked. And if there's a chance that something changes, that becomes our focus. And you come out of survivorship clinic and we take care of that. That has required a lot of reassurance for our parents. But it's important to know that just because you're now a survivor doesn't mean that we take off our oncology hat and say we're no longer looking at the brain tumor. We're still looking at it. And hopefully that provides some peace of mind so that you can focus on the rest of your life. So there, again, there's a benefit of being in a neuro-oncology focused clinic, so that someone who's used to looking at brain MRIs and spine MRIs is able to do it for you and go through those MRIs in clinic with you, and so that there's no doubt in your mind that nothing is changing. And then again, there's no standard of care regarding surveillance imaging. That's something that our team is starting to look at this year. So if you've had a medulloblastoma, do we do MRIs every year? When do we go to every 2 years? When do we go to every 5 years? Is it imaging for the rest of your life? These are questions that our families have that we're struggling to answer, and there's never been a cohesive answer. As a team, we know what we're comfortable with, and right now it's annual imaging until, depending on the brain tumor, and then if you have a low-grade glioma, we space them out a little bit. But we're looking to see what is the best approach so that we're not overdoing it as well. We know for our kids that are in college, it's a big deal to come back and get an MRI. For our little ones that require sedation, it's a big deal to get general anesthesia every time. So these are not, we don't want to overdo things just to make sure that we can sleep at night. We want to be able to do things in an efficient, practical manner that benefits everyone. These COG guidelines I put in the handout because they're accessible by anybody. So you can go online and look at these yourself. And it's important to know what exactly, again, that you're at risk for. So this is the website. It's just on the internet, and anybody can go to it. The way COG does it, it looks at your risk based on how much radiation and chemotherapy you received. So what we do is we go back through all your roadmaps and total up the per meter square dosing of every single chemo drug you've ever received. We actually look at the physical doses. We sit there and we add them up and to see what exactly happened to your body. Then we can tell you, based on this amount, you are at risk for these things happening, or you're not at risk for these things happening. The same thing with radiation. What was your dosing of radiation and where was it? And again, that helps us know what your risk is. Outside of the COG guidelines, because they're not brain tumor specific, if you're in your oncology team or your neuro-oncology team knows what you're at risk for based on what happened to you when you were on therapy. Maybe you had meningitis during therapy, maybe you had problems with eating, maybe you had all these difficulties that we still need to keep in mind moving forward. So again, it's important to be in a place where people know who you are and can help you with that. Passport for Care is this online portal that our nurse practitioner, Katie Valentino, is going to give you a quick tutorial on or PowerPoint on. And it's a way for us to give you consistent medical care, but it's also accessible now by parents and patients. So you can be away at college and you're seeing the health care provider that's local to you, and you're able to access exactly what your medical history is. You don't need to call us. You're welcome to call us, but this is a national thing. No matter where you are in the country, or the world for that matter, you have access to your medical records. And they're not volumes and volumes of paper. It's a very succinct, these are my medical problems. This is who I see. This is my last visit to this clinic. And every survivorship clinic in the country has access to this. It's not just here in Chicago. So this is taken from the survivorship guidelines. What's the purpose of the survivorship clinic? We monitor and we manage physical late effects. So that right arm weakness that got better, but it never really went away. It bothers you on some days, it bothers you on another, and then we delve further and it's like it hinders you from playing sports. All of those things are important to us because we want you, again, to live a good, fulfilling life. We provide health education to survivors. We provide referrals to subspecialists. We encourage wellness and health promotion activities, and we address our psychosocial needs. A huge focus of our clinics are to provide intervention for educational and vocational needs, assist with financial and insurance issues, because once kids turn 19 to 20, that seems to be so difficult so difficult of a transition time. Guide the transition for pediatric to adult-focused health care, empowering survivors to advocate for their own health care needs, and facilitating survivorship research. My idea of a core team is different than other people's, I believe. My idea of my STAR team is a dedicated oncology medical team. So an oncologist or an oncology-based, neuro-oncology-based nurse practitioner, our social worker, a psychologist, our neuropsychologist, and a school liaison. These are the things that our parents have told us and our survivors have told us are most important to them in making a difference in their day-to-day life. Subspecialists are important to us, but we try and get them to be there in our clinic as much as possible. But I see them as kind of ancillary. So we have a great relationship with our endocrinologist who's focused on children with brain tumors. Oncofertility, we refer all of our kids to that. Preventative cardiology and weight management. We know that our kids often are unable to exercise as much as they would because they might have very subtle physical functioning issues, and that's important for us to focus on and be able to get them an exercise program for weight reduction and BMI reduction. and then physical and occupational therapy. So what can our survivors and their families do? I can't emphasize this enough. Take charge of your health. Once you've gotten kind of over the shock that you've received, you've gotten to the survivorship level, you're that far out. My hope is that wherever your medical team is, you feel good about the fact that they will continue to look at the brain and spine MRIs to make sure that nothing has changed. So you can put that in the back of your mind and now focus on all these other things that can make your life better. When you have a child that is ill with something like this, there's always mourning at the beginning of your treatment of what that child could have been, what their potential could have been. But at some point, you have to stop thinking about that and realize if your potential was here, just because it's reduced now doesn't mean it's gone away. So you have to embrace the fact that you have room to grow. You can learn. You can have a career. You can have a family. And that's something very basic that once kids are done with their therapies, they sometimes often forget because they're still in therapy mode and just getting by and just trying to survive. But you've survived, and now it's time to focus on the rest of your life. And that's something that we try and emphasize to every patient and every parent in our clinic. How do we reach your full medical, social, educational, and psychological potential? Don't be afraid of using the resources that are available and pushing your healthcare team, including us if you belong to us, about finding resources in your area and things that you need. Trust us, but don't be afraid to ask questions. Again, that's why we go through MRIs with our families and don't just give you the report and say everything's okay. We want you to feel like you know your child, and we want that child who's now a young adult to feel like they know their own body and they know what they went through. Seek out survivorship clinics in your area. And this is not an area that is ripe in research just yet. We are attempting to be on the forefront of that and starting to answer some very basic, simple questions that we have found are coming up. So we're actively seeking grant support for those things. Arm yourself with knowledge about your disease and about your own health history. Again, the patient portal or Passport for Care will be instrumental in that. And if you notice, this talk was, I added some medical graphs and things like that because I want you to know that there's no aspect of your care that's beyond your grasp. So the things that we talk about as physicians and as nurse practitioners about the nitty-gritty of Medulo or all these other brain tumors, we can discuss with you. If you're in the right situation with the right medical care providers, there's nothing outside your grasp to understand. That doesn't just go for parents, that goes for our kids too. You should be in an environment where someone's going to be able to sit down with you and explain things to you in a way that you can understand. And I think that's the focus of our clinic as well. So just a quick slide about who we are. Like I said, we started 3 years from the end of treatment. We're located at Lurie Children's Hospital. We've recently established a transition clinic with Northwestern. So for our young adults who are transitioning outside of the realm of childhood, we often, for years, would not send them to the adult oncology survivorship clinic because we were uncomfortable with no one looking at their MRIs. So now we've established a relationship with a really wonderful adult neuro-oncologist who's very adept at looking at those things, as well as an internal medicine physician who can manage the rest of the survivorship issues. We obviously work closely with our social work team, our wonderful neuropsychologist, our school liaison, endocrinology, and fertility. That's really our core team right now. Our approach is to look at disease surveillance. We then look at late effect surveillance at treatment. We want to motivate patients to define their new educational and social potential. One question we always ask kids when they come to clinic is, what do you want to be when you grow up? And they often don't know because a lot of times people haven't asked them that because no one's thought they could grow up. So if they don't know, we challenge them the next time we see you, tell me what it is. Tell me what it is. It can change 5 minutes later, but have something in mind. And you can see their faces light up when they're young because now they understand that potential is there and they can think about it. We encourage independence in our late adolescents and young adults. And we wish to provide our patients with the same dedication and expertise we provided them when they were on treatment. And that was our main goal in establishing this clinic. And that's it. If you guys have questions, we can save them for the end. I'm going to introduce Katie Valentino. She's our pediatric nurse practitioner, and she's focused on pediatric brain tumors, and she helps me run our survivorship clinic, and she's going to review the Passport for Care online module.
Hi everyone, I'm Katie Valentino. I'm a family nurse practitioner working in neuro-oncology. I'm going to talk a little bit about Passport for Care and how we use it in our clinic to help facilitate care. So as Dr. Smiley already mentioned, pediatric cancer survivorship is an ongoing population. Over the last 3 decades, survival rates have improved significantly, resulting in a larger population of cancer survivors. Today, with the help of chemotherapy, radiation therapy, different surgical interventions, and improved supportive care, the 5-year survival rate for pediatric cancers is approaching 80%. This improvement has resulted in a growing population of pediatric cancer survivors. Survival, however, is not without a cost. Approximately 2/3 of patients experience some sort of late effect in their treatment, or from their treatment, I should say, and about 1/3 of those will experience a late effect that is serious or life-threatening. Even more is that the risk of these, the development of these late effects does not subside over time. There's no plateau noted. So the potential is ongoing throughout the adult life. So this is a nice graph that gives a great summary of different late effects that one can have from treatment of childhood cancers, any kind of childhood cancer, but specifically brain tumors. Most importantly, organ damage, we focus on a lot. So we look at cardiac function, we look at endocrine function, we look at the GI system, at the liver, we also look at the lungs. Musculoskeletal is a big piece or a big component of what we're also looking at, and then neurological function. We look at growth and development. So not only do we look at skeletal maturation, but we look at linear growth, as Dr. Play-Smiley had said. We look at emotional and social function, intellectual function, and also sexual development. We talk a lot about fertility. We talk a lot about reproduction. How does that affect the health of our offspring? How does that affect you having children in the future? And then also looking at, did the treatment you receive have the potential to cause a secondary malignancy? Can it result in recurrence of your primary tumor? And then lastly, psychosocial. So we look at mental health. We're really big on education and focusing on employment. And then also financial responsibilities. So health insurance, how are you getting by day to day, things like that. So what is Passport for Care? As we already discussed, child and young adults are often at risk for serious health complications. So Passport for Care is a nice database that was put together by 2 major health organizations. It was headed by members at Baylor College of Medicine and then Texas Children's Cancer Center. And it addresses the needs of survivors in a comprehensive and a cumulative way. And so this electronic database allows us to look at treatment and really individualize it to the survivor themselves. It allows us to look at different follow-up recommendations provided by the Children's Oncology Group, look at different screening and how that affects our potential for late effects. This program was first launched in 2008, so it is still a fairly new application that we're using and we're starting to grow into, but it's a great way to help guide not only families and patients, but also clinicians in terms of managing these late effects. So the Passport for Care website has been designed to contain the following elements. There's a guidelines generator, and so this is a way that recommendations are put together, individualized for each survivor. it takes into account your surgical history, your chemotherapy that you may have received, radiation therapy, different sorts of supportive or targeted therapies. All of that goes into this, this generator, and then it helps us to look at, based on those therapies, what are we at risk for? As Dr. Smiley said, some chemotherapies put you at risk for cardiovascular disease or limitations in heart function or pulmonary function. So all of that helps us to generate these guidelines. It also creates a nice end of treatment summary. So it ultimately allows us to develop a comprehensive and 1 to 2 page document that you can take to your pediatrician or your family practice doctor or internal medicine doctor and say, here, this is everything that I received, all the drugs that I received, all the therapy that I received while I was going through treatment for my brain tumor. And then lastly, it provides us with individualized survivor education resources, otherwise known as health links. And these are all patient-focused. They're based on the disease and the treatment, and they're designed to empower the survivor and their families to help facilitate follow-up compliance. So why is this important? Survivors themselves are often very unfamiliar with the treatment that they received. Not necessarily the treatment, but the very fine details. It's very hard to accurately portray this information to another care provider because there's so much that goes into treating patients with pediatric brain tumors. And so being able to accurately share that information is challenging. And so this helps promote independence with the survivor. It helps us to allow them to talk about things or show somebody what they went through without feeling lost and without having the support that they need to talk about those things. It's also important because primary care providers are often very unfamiliar with cancer treatment in general. They're very unfamiliar with what it entails to go through radiation or different chemotherapies and what those late effects are related to those drugs or treatments. So it helps us to provide family practitioners or internal medicine physicians great guidelines in terms of follow-up and lifelong care of pediatric cancer survivors. So ultimately, the goal of Passport for Care is to help pediatric cancer survivors achieve optimal physical and emotional health. And that's it. Any questions?
How long can the kids go to the survivorship?
So that's something that we're still in the process of kind of sorting out those fine details. A lot of it is based on the insurance that's provided. We potentially can see children up to age 26, but are beginning to think about transitioning around age 18. And that, like I said, a lot of it is based on your insurance coverage and what care, we want to financially support you as best as possible. So being able to provide the care in the most financially available way. Yes?
How does the advent of the Affordable Care Act factor into that?
In terms of survivorship care?
Yeah.
So Natasha, I don't know if you have more to say on this, but I think overall we're seeing a lot more patients who do have insurance, whereas before a lot of patients were self-pay because that is a new law. And I think that even though these marketplace insurance providers have different guidelines and support you in terms of seeing a provider, it may not focus solely on pediatric survivorship and cancer survivorship. So there may be an earlier transition period based on those marketplace insurance, maybe as there would be with Medicaid, something of that nature. Any other questions? Yes.
You keep referring to the Passport for Care. Is that a website that you can go to and log into, or where does that come into play? How do you locate that?
So Passport for Care was originally designed for providers to use. And so what we do is we go in and we abstract data. We look through the old paper charts, we look through electronic medical records, and we try and get a really nice selection of data, and we input that data. And then a newer feature of the program is parent and survivor access to the program. So what we do is we then, once all that information is compiled and abstracted and inputted into the system, we are able to print an access code for families, similar to something like MyChart with Epic. And then with that access code, we provide you with a link to go on the website. You enter the access code, and then you're able to always access that information and data.
So prior to someone coming into our clinic, like Katie said, we go through everything and tally up there's a lot of math. We tally up all your chemotherapy and radiation doses and put this into the computer system. We print it out for you so you know these are the numbers, but then based on these numbers, these are the things that we look for. And we hand it to you in our clinic visit. But we now also hand you, well, Katie hands you because I don't really know how to give you guys the password and things like that, but it gives you a password that is only for the patient to use, and parents can use them if okay with the patient if they're of age. And that gives you access at home. It's just a website you can log into, just like Google or anything else.
He wasn't also followed by oncology. He's one of these rare few children that never had chemo or radiation. He never fell into the STAR clinic. He kind of fell off the radar. And I know over the years that they're following more of those children, but he's not on there. So would you be able to, or would you, with his upcoming appointment for follow-up, because it's also been 4 years since his last MRI, so he's due for one. And I'm sure a lot of people in this room are going, wow, 4 years and no MRI. But would somebody be able to take the time to input all of this information for him? Because still going forward, there's always been my concern about secondary diseases and things that he's at a greater risk for that have never really been addressed with us.
We'd love to see him.
I knew that was going to be.
Yeah, but you're describing a population, so most places don't have as big or as involved as neurosurgical care as we do, and we're blessed to have that. Most hospitals, once the tumor is out and once you're kind of done with treatment, the neurosurgeons kind of sign off, and that has not been our model, thankfully. And there is a subset of kids that we've never seen, usually children with low-grade gliomas or ependymomas that were completely removed, never needed chemotherapy or anything like that. And we were just discussing recently what we do with those kids. But we would be happy to see them and get them involved. And even if it's just to go through your risk factors and then to see Dr. Powell to see if there's any neuropsychological issues from the location of the tumor and the tumor resection, that's something that is definitely worthwhile doing.
So he should plan on camping at clinic for a day.
You can just tell us who he is and we'll take care of the rest.
Yes.
You mentioned this is a national program?
Yeah, so it's a national database that was created by Texas Children's Hospital and Baylor University, and it's more accessible now to multiple institutions.
So then, other institutions, they have to go to you to input that information?
No,
Or
so
they have access to that to input it as well, so that we get a one line chart view
Yep.
regardless of what hospital we're going to.
So the information that's inputted, I am taking from all institutions. So if you were seen, at University of Wisconsin, for example, and then you were seen at Lurie Children's, and I'm trying to combine all that information, and I then go in and input that data. And so all of that treatment should show up in your Passport for Care summary. But then it is accessible to other institutions who do have access to Passport for Care.
Thank you for what you're doing.
Thank you.
What do you do when your child's an adult and he's aged out of, survivorship clinics and all of that, and he doesn't follow up with an oncologist, he's in chemo radiation, and like that? How do you find, besides going through that long, 200-page child cancer survivor guidelines thing, find out what tests you need to go to his doctor and say you should be having this, and this done? How do you do that?
I think it's a great question. I think, people who are not being seen at survivorship clinics are, slightly at a disadvantage because, like we talked about, primary care providers are not familiar with late effects and different treatment effects. But I do think, getting in contact with the primary team to find out, the primary treating team, no matter how old your child was, to find out what therapies he received and what potentially risk factors he's, has. And then trying to portray those and convey those over to the primary care provider is probably the best way to do that because it is a long document. It is a very large PDF file to go through.
Yeah, one of the things about being a pediatric oncologist, no matter what your subspecialist is, we don't let go of our kids, even when they're in their 30s and 40s. So if you contact wherever he was treated and ask them for a treatment summary, then they'll give it to you, and then I would take that to his internal medicine doctor.
Internal medicine, only a family practice.
That's fine.
But
No,
that's okay.
So may I ask where you're located?
From Wisconsin. And his health insurance doesn't let him go to any of the big teaching hospitals or anything. So, you know,
Where was his oncology care?
well, we started out in Milwaukee Children's.
Okay. Okay. They actually should have, Milwaukee Children should definitely have access to Passport for Care. So maybe when you call them, you can just ask them, instead of just giving me a written summary and a letter, can you just give me the information from Passport for Care, the printout? And then that will tell them exactly what they need to do. The other thing is, if you call them with this concern, they'll make sure he finds the place that he needs to be for his follow-up care.
Yes.
Once they do age out of your survivorship clinic, where do you send them then? Do you transition them, you said, to Northwestern, or where do they go?
So as Dr. Smiley mentioned, we recently established a great relationship with the neuro-oncologists at Northwestern. They also have a survivorship program, so we're able to transition our patients to Northwestern to see both the neuro-oncologist and the survivorship team, which will help manage all of these ongoing issues.